All righty, folks. Welcome to it. As always, Keith, Respiratory Associates, always appreciate y'all having me. My name is Chandler, currently a pulmonary disease navigator and respiratory care educator. And what is neat about what I kind of get to do in this role, other than being a navigator, is that I have the opportunity to, or I have had the opportunity to go in and one, get to spend a lot of time with my patients, but two, I get to do some things that maybe not a lot of us respiratory therapists get to do. For instance, peak inspiratory flow rates. I didn't really remember this so much from when I was in school, but as we get into practice, of course, we learn things, right? Or maybe rather, we are reminded of things. So one of the things I get to do is go in and I get to do this peak inspiratory flow rate. It got me thinking: inhaler use, readmissions, quality of life, that kind of thing. And I said, well, I want to see how many of these folks are able to even use their inhalers and use them appropriately. So we're going to look at peak inspiratory flow rate and hospital readmissions. And the study that I've self-published, you find it on LinkedIn or ResearchGate, what have you, is assessing the effective use of home inhaled medications based off peak inspiratory flow rate. We'll look at the implications for COPD management and hospital readmissions. A couple objectives we want to look at. We want to define and discuss COPD. We'll look at the social, the economic, and the individual hindrances that we see and that I see as well. We'll describe peak inspiratory flow rate and its importance. I see undervalued importance, inpatient and outpatient. We're going to discuss this research step by step, how I looked at it, how I went about it, and maybe some of the limitations that I came across. Then we'll look at and evaluate the need for common peak inspiratory flow rate measurements in terms of, right, you're the respiratory therapist, you go in and to kind of save some time, I guess, in a way, or, we see with COVID and other airborne diseases that these patients are on inhalers. We go in and we assess. They're in the hospital with exacerbation, more than likely. Are they able to use it? Are we, I won't say wasting our time, but are they able to use it? So we'll evaluate the need for common peak inspiratory flow rate measurements. So we'll look at the background a little bit. So COPD, it's a progressive lung disease. We know this, and we know that with emphysema or COPD, we'll call it this emphysema. Most of these folks are, if all of these folks are smokers, but we look at it as a progressive lung disease that often leads to hospital admissions due to exacerbation of disease and that kind of thing. Effective COPD management is crucial. And we'll see right here in just a little bit how some of these, the literature that's come out shows that maybe not all these folks are being treated the way they should. So effective COPD management is crucial, and proper inhaler use is essential. Peak inspiratory flow rates, or PIFRs, and I'll use that kind of as we go forward. It's a simple test, super duper simple test that measures inhalation flow, and it might be a valuable tool. I can't really 100% say. I mean, personally, I say it's a very valuable tool, but it might be a valuable tool to ensure proper inhaler use. So we look at the methods. So this pilot study investigated peak inspiratory flow rates for hospitalized COPD patients. And we'll see hospitalized. Don't get too caught up in that just yet. It was a prospective observational study with 50 participants at a single hospital. Researchers excluded nebulized. So I excluded those folks that are on nebulizers and those without a true, or as we can see now with grade 0 or PRISM, without this kind of the COPD diagnosis, especially as we see it in the chart. PIFR was measured at subjective baseline, and I'll say this too, when I say subjective, that is the patient's. Yes, I'm feeling like I'm right about where I need to be. I'm at my lung baseline or my pulmonary function baseline, as well as contacting the physician. Hey, how do they look? What do you think? So that was measured at subjective baseline, and medical records were reviewed. And I say reviewed, I review them anyway, but reviewing for, are they back down to their home oxygen? Are they able to ambulate the same? That type of thing. So I followed these patients for 6 months, and I always do anyway, to track those readmissions. And because I was solo on this and, it still had duties of the job, I had to limit kind of that sample size and limit how much actual data, like for month to month, for instance, for 30-day readmissions. So I tracked them for 6 months. And we look at the results which were surprising. 74% of patients had a peak inspiratory flow rate that was below the optimal level for their inhalers. I would say that, and I didn't track this, but literature supports also that I would bet 60 to 80% or more were able to use their HFAs, PMDIs, that kind of thing, but were too good, is what I tell the patients. They were doing it too well. So 74% of those patients weren't able to use them effectively. Medication changes based off peak inspiratory flow rate were carried out for only 20% of the participants, and that was at the attending physician's discretion. Some of those folks, they don't really want to step on toes or, that kind of thing. The study found a number of weak correlations. Additionally, chi-squared and Fisher exact tests resulted as inconclusive, but may point towards PIFR-based medication changes. And we'll look at what this inconclusive kind of means. And we'll say, and I'll continue to say forever and ever and ever, further research is going to be needed, especially as we see these different phenotypes, different lung diseases, IPF, that kind of thing. These folks are still on inhalers, right? But it's inconclusive at this point, and we'll see kind of how that lays out in just a little bit. However, this study does offer some inconclusive evidence, but evidence concerning PIFR-guided therapy. Larger, multi-centered studies are needed to confirm these results and understand the long-term impact of pretty much follow-up PIFRs, right? Every time you go see your pulmonologist, right, you get a PIFR done. I don't readily see this in very many charts, folks. I promise you, I would say I see this in less than 5% chart, outpatient and inpatient. So we need larger multi-center studies, more patients, and really bring this out to the general folks. So look at COPD. All of us RTs, right? If you're not a RT, we're probably in healthcare, but most of us know, we know what our COPD patients are. We know who they are, what they're going to do. A lot of the times, if they're going to wear BiPAP, right, if the meds are actually helping, are they a blue bloater, pink puffer, what have you. COPD is characterized by chronic respiratory symptoms such as dyspnea, cough, sputum production, and or exacerbations due to abnormalities in the airways, bronchitis, bronchiolitis, and or the alveolus emphysema. And of course, we know cystic fibrosis, bronchitis, chronic bronchitis, asthma. Those are all our COPDers, right? So it's mainly, I won't say mainly, a chunk of this is a result of smoking, tobacco abuse, as well as exposure to occupational, which I hardly ever see documented in the charts, and environmental hazards such as biofuels and pollutions. 15 to 17 million people in the United States with COPD right now, most of them diagnosed in later stages. 392 million, quote, COPD patients worldwide. Scarier, it's expected to rise by about 200 million by 2050. 200 million. Sheesh. Folks, that's a little much, right? It's the sixth leading cause of death in the United States, third leading cause of death in the world, and third leading cause of readmissions in the United States. Should be fairly important, right? And I always say this too, we have a lot of cardiac hospitals and congestive heart failure, which I also navigate on as well. Congestive heart failure too, but you never really see COPD hospital of excellence or what. Third leading cause of readmissions in the United States. Sheesh. 923,000 emergency room visits, and likely growing, as we see with our new 200 million by 2050. 923,000 emergency department visits and nearly 700,000 hospitalizations each year as a result of COPD. Average 30-day readmission rate is roughly 20%. And this can range, I've seen ranges from 18% all the way up to 24%. at an expense of about $15,000 to $20,000 per readmission, and that can be also as high as almost $50,000, some literature states. Generally occurs during the first 7 to 15 days of discharge. Highly important to think about that, especially when we're cruising off of this exacerbation and we're not able to use our DPI, for instance. Indirect cost of this, $50 billion. Direct cost, roughly $21 billion. So we're looking at a rough $71 billion a year with COPD. Between 2019 and 2038, it's expected to increase to $1 trillion with a T US dollars. It's significant, right? Let's do a quick little brief review of literature. Research has explained that among patients admitted to the hospital for an exacerbation of COPD, more than 1/3 did not receive recommended care. 33% did not receive recommended care, contributing, as it should, to concerns that the high rates of readmissions reflected poor quality of care. And if we've ever sat through my health disparities lectures, or if anybody's ever talked to me about health disparities, we know that the costs aren't matching the outcomes. So I find it very concerning, right? And I would think that this very much so is contributing with this poor quality of care. The GOLD strategy report provides recommendations for the treatment of COPD, including monitoring, non-pharmacological interventions, and of course pharmacological interventions, and the appropriate use of inhaled medications and their associated delivery devices. So folks, I mean, I've talked to pulmonologists, I've talked to respiratory therapists, I've talked to all sorts of folks, right, with us. And generally, historically, there's just been a kind of a lack of guidance. I remember learning about inhalers, of course, in school. And maybe we went over they need to generate this much flow, or they need to take a big deep breath with this one, and maybe not such a big deep breath with that one. But historically, there's been a lack of guidance, like a really concrete, stone cold way of going about it. Concerning prescribing inhaler devices, much of the selection is based off insurance coverage, of course, right? I would love to get a patient a PMDI of, LABA-LAMA ICS, but maybe their insurance, most of the time it seems, is only going to cover that DPI. We look at the GOLD strategy, mentions determining the appropriate inhaler is important, while retrogressively reporting that proper medication usage adherence is low for COPD patients. So, patients that come in, we look at, it's not really, what is it? They don't want to call it non-compliance anymore. They want to call it non-adherence, I guess is the correct terminology we're being told. Some of these folks just don't use it, right? Take this inhaler once a day, and half the time they forget about it. It's wild stuff, which there's also some even cooler things coming out in the way of monitoring, telemonitoring of peak inspiratory flow rate, FEV1s, and that kind of thing, which I've been in talks with some pulmonologists and some folks about. Hopefully we can get something started there. Potentially valuable data point, as hopefully you've got by now, is the peak inspiratory flow rate. Once we get it, we can pick the device. It's the meds. Sure, the meds are highly important, but if they're not able to inhale those medications appropriately, they don't really work in your mouth very much, right? So let's look at PIFRs. What is it? Okay, some of you folks may be like, wait a minute. I think I learned that back in maybe freshman year, maybe your second semester, going over some PFT stuff or something. What is it? Again, it's a very simple procedure that involves the patient inhaling through a device that can mimic the internal resistance of certain types of inhalers. Super easy. Why is it important? Of course, as we said, the appropriate inhale device with the most optimal, and we'll clarify these things, most optimal use can be easily selected. Routinely evaluating the effective use of prescribed COPD management medications with PIFR as a biological marker is fundamental. It's a fundamental step to optimizing patient care, decreasing those admissions and readmissions. Sometimes you got to catch them there, right? And improving those outcomes. What I use the Clement Clark. You can see this is kind of one of the things that they give you. I think I've got 4 or 5 of them now. But so I use the G16, the in-check dial PIFR device, which provides a quote clinically effective range. Okay. So this is essentially how I documented it in the chart. For the study, it was documented as a separate note, whereas the majority of the time, it is just included into that note now because if we do it for, or I do it, I'm the only one there, but we do it for every single patient. So that's what it looks like. Peak inspiratory flow rate, assessment details. We use the device and the technology we're telling them. I use the in-check dial, instructed the patient to take a deep breath and exhale fully before inhaling as forcefully as possible through the device. And we did that for the medium low. We're looking at DPI type inhalers. And then I would kind of skip back and do that PMDI. I didn't want them to work on the PMDI 15 different times and then be too fatigued to try the medium low. But I would do the medium low first, and then we would come back around. And the low resistance had no patients with a kind of that low resistant, the in between the soft mist, PMDI, HFA, whatever you want to call it, in the DPIs. And then I interpreted it. I looked at effort. Did they do poor, fair, good, great? And based off this, and I would say this as well, based off the inspiratory flow rate values above, the patient's inspiratory flow rate is adequate or not adequate and does or does not meet optimal flow for current inhaled medication therapy. So I kind of looked at this. I went through a lot of different literature, tried to compile all of these things together. And of course, if you read through the paper that's posted, of course, you can kind of see a little bit more in depth about these things. But when we're looking at these DPIs, okay, we'll clarify just a little bit too. The resistance, when we're talking about resistance of the inhaler, essentially we're talking about what do I need to overcome to bust that medication up and get it into my lungs? Okay, what is the resistance there? So we're looking at R1 to R4 as described on the G16. And when you look through the paper, you should be able to see the medications listed with these two. Optimal, greater than or equal to 60 liters. Okay. And as I stated, a good majority of my patients were too good for their albuterol inhalers and things like that. So that 20 to 60 for a non-restricted, is fairly easy to get. But that R4 and the R5 is the resistance needed to overcome the inhaler to disaggregate that powder. And then with our NEBs, generally normal tidal breathing. So let's look at some clarity here for a second. So we're talking about minimal, optimal, right, resistances, these types of things. So when we look at minimal, we'll call that the actuation flow. It's the flow needed to overcome the internal resistance of the inhaler and receive some clinical effect. Optimal flow, however, is achieved when the patient can overcome the inhaler's resistance and deliver the highest amount of medication to the peripheries of the lung, yielding, you would think, right, the highest intended effect, which is what we want, which is to dilate those bronchial tubes and decrease that shortness of breath and minimize those readmissions. For instance, and I'll say this here too, researchers pointed out that dry powdered medication deposition can be as low as 15 to 40% depending on the inspiratory flow and effort. I know that AstraZeneca and a couple other people or organizations have come out with literature that shows the actual radioactive deposition into the lungs. And when we're looking at our grade 3, grade 4, grade 1, 2, 3, 4, but we're looking at these severe, very severe lungers. I just don't think 15% is going to do much, right? 15 to 40%, again, I just don't think that's going to do much. Let's say at 30 liters, we're still getting 40%. I'm sure it's helping, right? I'm not going to say it's not hurting, but it's probably not hurting. But then if we can hit, for instance, that 60 liters and bump that up to above 40, 50, 60, lo and behold, 100% in a perfect world, right? That we should be able to improve that patient's care, optimize that patient's care. Once we get that PIFR, the PIFR measurement, devices that the patient can effectively use can, from there, very easily be selected and potentially prescribed. One of the things that we can do for navigation, or I don't know if like other folks do this or what, I'm sure physicians or whatever do, but once I get this PIFR, I can look, and I'm no big insurance guru, so I get a hold of my pharmacy buddies and I'm saying, hey, they need this type of inhaler, this type of medication. Can you run it through, see what it's going to look like? Sometimes we'll need that prescription sent down to the pharmacy, but other times, and some other times they can roughly tell me based off the insurance how much is prescribed and that kind of thing, about how much it should cost. Insurance, y'all, in terms of optimizing care, I have found is the biggest barrier. So let's look at the nebulous. What is all this confusion? Why is all this kind of this back and forth going about? So there's just very little research concerning peak inspiratory flow rates. I mean, I think I had in a stack everything about that I could find. Okay. Just with peak inspiratory flow rates, let alone, derivations from spirometry and that type of thing. But so we look at these confusions. Some of the other confusion comes from providers. There was a study done where roughly 513 prescribing providers were asked, they were like, hey, what's more important, the medication or the delivery device? And 89% of them stated that the medication selection is more important than the delivery. And for me, this is highly confusing. For instance, we have these rescue medications, and we'll kind of talk about that a little bit too. We have these rescue medications that are essentially to help to, I won't say prevent, but to alleviate these eventual exacerbations or these eventual episodes of shortness of breath, bronchospasm, that type of thing. 89% of them. Is the medication important? Well, yes, right? If I could get a LABA-LAMA ICS, depending on EOS, 100%. But if 99% of it deposits into my mouth, I've got thrush and everything. So if all that deposits into my mouth, it'll make a lot of sense to me. Other research states that peak inspiratory flow rate and medication deposition depends on many factors intrinsic to the device, the patient, the proper use. Okay, and we'll see how the proper patient or so looks at. Other studies researching the same types of inhaler devices, such as PMDIs, small mist inhalers, suggest that PIFR is independent of deposition before or after coaching. So some of this literature it's a little bit back and forth. And the verbiage and the way they kind of go about it sometimes is a little bit confusing. So one states that, it's intrinsic to the patient, the proper use, the device. So said it's independent of deposition before or after coaching. Of 303 patients, I believe this was COPD Foundation, 20.1% were resulted as not having optimal PIFR, and that this suboptimal finding was more prominent in females less than 65 inches, which was roughly 27% of their patient population, or that statistic, and that was more so in the shorter, heavier set individuals. 383 COPD patients, there was a significant reduction of exacerbations, not surprising, in their PIFR-guided inhalation group versus the conventional inhalation medication education provider, take a big deep breath, right? Or their control group of 11.9% versus 21.2%, right? It's pretty decent. Looking at 10% there. Other researchers throwing into this whole nebulous here, work suggests that the improved device selection could reduce index admissions and therefore, of course, those readmissions. Because you come to the hospital, right? They make you lay in a bed. Essentially, to me, a lot of folks just get a little bit weaker muscle-wise, maybe stronger lung-wise. These same researchers also found, and this is right, I said that a good chunk of my patients, at least I'll say of this 50, I won't comment on the probably 1,000 or so that I've already done. But, I said 60, 80%. These folks found that 87 to 90% of PMDI and small mist inhalers were not being utilized effectively until that peak inspiratory flow rate guided intervention and education. 90%. And we know those PMDIs as rescue medicines, right? We've got Combivent, right? That Respiratory, not utilizing them effectively. Rescue medications. Got up this morning, I took my maintenance meds. And, as we know with some of these patients, I took my maintenance meds and then, I just got real short of breath. I took my albuterol 15 times and never did feel any better. It's what I like to call spray and pray, right? They spray it and pray that it works. I'm hoping that this works. Researchers pointed out two important studies. One states, and we still look at this nebulous, one states there was a significant increase in 90-day readmissions for patients with suboptimal PIFRs, and the other study suggests that there's little difference with those with PIFR-related therapy versus non-PIFR-related therapies. And this is in Mailer's research. All of my references will be in the back if you want to look at it, kind of compiling, almost in the same fashion as I have, kind of compiling this research data. Right out here in good old North Carolina, some researchers found that during an acute exacerbation of 123 COPD patients, that 52% of those patients did not meet the 60 liters per minute flow rate at the unrestricted resistance. That's unrestricted, folks. Not even hitting 60 liters at the unrestricted. Again, unrestricted is HFA, SMI, okay? Those are the things that you're not supposed to take big deep breaths with. 52% of them didn't meet that. And that their PIFR did not vary substantially during the acute exacerbation phase, regardless of the day of evaluation. Kind of see what I'm saying? Once they're in this exacerbation, and we know this, that lung function declines some. So they found here 52% of these folks, okay, 60 some odd folks, they didn't even meet the 60 liters at the unrestricted. So we see some problems there, right? We see a little bit of cloudiness in. And we know, of course, hospitals are strapped for staff and time and money and all that other junk, okay, which can sometimes make it a little bit hard. I'm not a prescribing provider, so I can't ask these patients to come to my office so that I can follow up with them, get their outpatient PIFRs and those types of things. Ergo's one of the limitations, of course. So I try to approach this in a smart way. So we look at specific, measurable, achievable, relevant, timely. So specifically, we wanted to evaluate the objective effectiveness of currently prescribed COPD management medication based on PIFR. Okay, measured PIFR versus the patient's inhaled medication requirements. Is achievable by utilizing these standardized kind of procedures, sedated discharge, or at subjective, you and the physician think you're at subjective lung function baseline, or as close as home as we can get. And then relevant, of course, is relevant. It's an important indicator of airflow limitation and medication dispersal in the COPD patients. We look at time-bound, peak inspiratory flow rates measurements were obtained during the hospital stay for each of these participants. So we look at the study design. The participants, this research study utilized prospective observational cohort design to measure peak inspiratory flow rates for hospitalized patients with chronic obstructive pulmonary disease. And we can kind of see here the ladder of evidence, that kind of thing, right? A hierarchy of evidence. Of course, it wasn't a meta-analysis or a systematic review, random control trial, none of those things. But for these participants, included hospitalized patients with a primary diagnosis of COPD who met the inclusion criteria of 18 years or older, diagnosed with COPD are at expected baseline lung function or on the day of discharge, which all of these were actually on the day of discharge, and currently prescribed COPD maintenance medications other than nebulizers. So we kind of look at this. I like to throw that grade 0 prism early COPD in there. A few of those folks, of course, we refer those out to lung volumes, that kind of thing, but they're in there with COPD. PIFR was measured at baseline lung function following standardized procedures recommended by Sanders and O'Hare. And they kind of lay out a means of, hey, this is how we want to try to do these things. For validity, we're looking kind of at this airflow limitation that the same folks from North Carolina said that they of 159 patients, inpatient spirometry had a sensitivity of roughly 94%. positive predictive value of roughly 83%. Now, it is saying that in some regard, 53% of those patients may have been inaccurately labeled based on grade, but 94% specificity in terms of you've got COPD. Data on patient demographics such as age, gender, social determinants of health, COPD severity, length of hospital stay, discharge medications, readmissions, smoking history were collected through review of electronic medical records and, of course, talking to the patient. So we look at, in total, average length of stay, and I'll note here too, and I'll talk about it in just a second. A good chunk of these patients, by the nature of my job, were considered high utilizers, friendly faces, what have you, a good amount. So we look at a total average length of stay of about 8 days, which is not super great for these 50 patients. One of them, I believe, was in for 20 some odd days. We look at age as a total average of about 67. And if we look at some of the data or some of the literature, I guess, 40 years old to about 65 years old, those are the folks with the most kind of readmissions, depending on the literature you read. So that kind of makes sense. Look at the peak inspiratory flow rate, total average of about 43. Jeez. Still not at that 60. Look at social determinants of health, such, a slew of things. You forage medicine, forage food. You got transportation, you use your medication, you have health literacy, that kind of thing. We're looking at about 1.6. I can't speak to the national average for social determinants of health per patient per COPD, but 1.6, I feel like that's fair. That's roughly about one thing that we can do to improve on that area, home health, whatever. We look at, feel like it was a fair amount of male versus female, 21 to 29. And an average pack per year or pack years is 50, well, let's say 49. And what I thought was surprising is we look at this grade quote 0, which kind of makes me think of this air trapping, right? 45 years. Then we look at grade 4 with an average, and this is just 50 folks, okay, of 29. Could speak to severity. So we look at identification and enrollment. Potential participants were identified through medical record review by the pulmonary disease navigator who approached eligible patients for enrollment in the study. An interview was conducted with patients in which other clinical data was obtained. I'm not just going to see them just for PIFR, I'm seeing them as patients as well. And that included peak inspiratory flow rate measurements, electronic medical record documentation of peak inspiratory flow rate measurements. And enrollment was then carried out. All patients opted for EMR documentation, so we scanned all of those consents into the EMR so they could see it. So that's 100% of them opted for it. I don't think any of them really wanted extra paperwork once they were leaving with the AVS or after visit summary or whatever you want to call it. Informed consent and the HIPAA forms were explained in detail to every one of the patients. And I would say half of them probably, I'd ask them, hey, do you want to go and study, whatever? And I'll say, you want to look over this form, you want to sign all this because, we have to, okay? And a lot of them were like, oh, no, it's fine, I'll sign it. And I would make it a point to go over the consent, what I was using, what I was doing with their data. And I always, of course, asked them if they had any questions about it and that type of thing. Consent was then obtained for each of the participants or their authorized representative, which I think I only had one, and that was actually patient opted. So we look at the background of medication management. The pulmonary disease navigator collaborated with the healthcare team to ensure that patient medication recommendations echoed the appropriate COPD management medication based off the 2024 GOLD guideline criteria or GOLD strategy, or however you want to coin it. And as I said, only about 20% of those patients were changed. And sometimes, in the hospital, got your hospital list, right? Everybody's got a ton of stuff going on. Sometimes we could see maybe it got lost in the text messages. Maybe they didn't have time to get it to them from the pharmacy or this, that, and the other, but only 20%. But know that I hound these physicians 3 days a week, 30 hours a week to follow GOLD criteria, or at least to, it maths up, right? However, this was a clinical duty instead of a research outcome for the pilot. So regardless of the research or any of those things, no matter what, and as I stated, I've probably done 1,000 of these things thus far. But I always, as a physician, it's not just about inhaled medications, but for pulmonary rehab referrals, outpatient pulmonary, outpatient therapy, outpatient palliative care, inpatient palliative care, so on, so on, so on. But that was more so making sure they changed or at least knew they needed to change those more of a clinical duty. And again, at the physician's discretion. Follow-up assessments, we set patient-specific alerts, they call ADTs, and review electronic medical records for 30-day all-cause hospital readmissions for COPD patients. Again, this right here also is a clinical duty as well. I set 6 months readmissions because, we get a patient that comes in at 31 days, I may not know about it. So we set 6 months. And again, in terms of staffing, we'll look at limitations. So data analysis, descriptive and basic statistics were used to summarize the demographic characteristics, baseline peak and story flow rate, and medication regimens. Simple statistical analysis was used to quantify the percentage of patients who are not currently prescribed appropriate medications, and took averages of lengths of stay and things like that. Basic correlative statistics were also utilized to draw any further conclusions if possible. So we look at the limitations. It's a single county, single center medical center. I believe it's about 850, 950 beds, but don't quote me on that. It's around about there. So it's a decent sized medical center, but being in one place, roughly 50 patients, it limits the generalizability of the findings. The study's duration and sample size, about 6 months, and the sample size of less than 100, as I stated, also impact the statistical and correlative power and generalizability of the results. And just with PFTs and labs and all other things, technician error as well as patient effort may also be a limitation. But of course, I feel like I did a great job. I'm sure, hopefully I interpreted the patient's technique and things appropriately as a respiratory therapist. Other variables not considered in the sample could influence outcomes, such as comorbidities, socioeconomic status, because it may not, in terms of how much money they have and those types of things. They could still have great insurance, so on and so forth, but full socioeconomic status and access to healthcare, among just a few. Of course, as an navigator, we try to limit those things. So let's kind of look at the results a little bit. So we had 50 hospitalized patients with COPD, and they were all included in the analysis. 78% of participants were Caucasian, 18 were Black, and 4% other. The mean age, of course, rounded up for our averages. The mean age of the participants was 66.9 years old, standard deviation 9.43. Average smoking history of 1.25 packs per day with a standard deviation of 0.58, and 49 years with a standard deviation of 28.34. There were some pretty big swings, as we said. Grade, I think it's grade 1 and 0, and we'll see in just a minute. They were fairly large smoking history, whereas those grade 4s, there weren't a ton of them. Those grade 4s didn't really have a huge smoking history. 42% of them were male, 58% of them were female. Again, I feel like that was a pretty good average there. And the average length of stay was 8 days with a standard deviation of 5.45. 26% of them were, quote, grade 0, grade PRISM. 6% were grade 1, 22% were grade 2, and 34% were grade 3. So a good chunk of them were either severe to very severe. 56% of them had moderate to severe COPD based off that GOLD criteria. A total of, and this is what really got me, okay? Again, we're at the bedside. I'm talking to the physician, all those things, okay? I'm trying to determine the best way that I can. They are as close to baseline as we are going to get. Roughly 74% of them, or 37 of them, were found to fall below optimal flow regarding their current inhaled medication therapy. And roughly 26 of them were on appropriate medical therapy, the LABA ICS, HFAs, that kind of thing. So if I look back at the data, I would say that 73.68% were DPIs. 20%, or 10 of those folks, their medication was changed to reflect optimal use. Only 3 of them were admitted in 6 months. And of those 3, one of them was, quote, high utilizer. So for 6 months, and these high utilizers they come in all of the time. I think it's 11 visits to the ED or 4 admissions a year, something along those lines. So they're correlatively weak, but is yet in line with other research. Average peak inspiratory flow rate for ages 64 and under was about 45 for medium low and 40 for those older. We have a correlative score of 0.027. And I was reading something just the other day that was talking about how those approaching older ages, 65 or older, or 60 and older, I believe is what the literature was saying, there's a significant drop in their peak inspiratory flow rate. And you can see that, I mentioned that also in the paper. But so it's correlatively weak. Again, we have to look at the sample size, but correlatively weak, but still in line with the current literature that we've pulled. An average peak inspiratory flow rate of less than 50 liters a minute for medium DPIs. Medium low was found in every single grade group. We'll look at this. Actuation for DPIs is about 30 liters. And this is where we get our clinical effective range, about 30 liters. And the optimal, again, is greater than or equal to 60 liters. So less than 50. Are we in that 15 to 40% range? Potentially, yeah, probably. Okay, 50 is pretty good. But every single one of them were less than 50 liters. 46% of them were high utilizers, and nearly half of them, 47% of them, did readmit in 6 months. Now, remember that only 10% of those patients had their medications changed, 3 of them high utilizers, and 1 of them readmitted. A total of 38% of folks, or 19 of those patients, readmitted in 6 months. Grade 3 patients represented the highest length of stay at a total of 134 hospital days. And, when we look at this grade, disease severity, we can also turn to our Z-scores, right, and say, all right, they're greater than 1.65, negative 1.65. Maybe the disease burden isn't as high. But with grade 3 or higher, regardless of bronchodilation or not, there is a very, lack of better terminology, very severe loss of lung function. Even if you're at your tip-top lung function, trying to function on a daily basis with a high disease burden, you're going to feel it. You're not going to feel. A lot of these folks don't feel comfortable going home yet. That kind of thing. 403 hospital days were recorded for all 15 participants. 403. And when we look at that 403, and now we're adding on 47% of those folks back in 6 months. Now, of course, we have 30-day, 90-day readmissions, that kind of thing. Good thing is, at least they only readmitted 6 months. Right. If you want to sit through my pulmonary navigator lecture, we can look at our readmission rates and things. Two-tailed t-test analysis comparing the mean grade, and this is where you use the t-test to compare these means together. The mean grade of COPD versus the mean peak inspiratory flow rate did result in a statistically significant manner. Got our P of set of less than 0.1, 0.05, and we had a P of 0.0000023. This suggests a strong correlation, if we use our correlative coefficients and things, between these two variables. So I've read literature that states that the grade of COPD doesn't really have much to do with inspiratory flow, that kind of thing. But when we couple in stature, weight, that type of thing, then we can see where that can come in. So this correlation supports the expected trend and suggests that COPD grade is a reasonable indicator of inspiratory flow. Again, though not the only factor. I mean, I've had grade 4 patients that still do push-ups and frog kicks, whatever that is, and to whatever extent, but they just don't look like grade 4 patients sometimes. And maybe it's because, for instance, the patient that comes to my mind was a thinner, I guess more, what do the kids call it anymore? More woke patient. She was very in tune with her body, very in tune with her medications and that type of thing. Probably in that 20-some odd percent that was on appropriate medication. And it comes with education, right? I will get into it. Don't get me on my soapbox. So this explains a moderate portion, around 40. This explains about 40% of this variation. The remaining variations, again, could be due to factors not considered or could be in a non-linear relationship. And our Pearson correlation coefficients were calculated for various factors such as grade versus length of stay, age versus length of stay, social determinants of health versus age. And I was kind of surprised there to find that weak correlation, again, in light of limitations. But, I've read different things. The most recent thing that I've caught up on states that these older individuals, when they do have these social networks, they are very strong. Again, we see with about 40 to 60 years old, there's a high disease burden, and that could be a result of maybe not having that support system. Okay, I'm not quite 40, but I live in North Carolina, and my family's far away, that kind of thing. The support system may be narrowed. We're working, we're moving, we're doing things. And then, of course, that will take a whole different turn for study. But then social determinants of health and grade. But I thought definitely that in my mind before reading through some of this literature, well, these older folks, man, they need a lot of help. These elderly, they need a lot of help. They may have higher social determinants of health. Interesting things. I wished I could have had a larger sample, and later possibly I will. So we look at the results. So when we're comparing medication changes and readmissions, I wanted to see, is there any type of relationship there? This is what I really want to put. If I change these medications as a navigator, if the provider changes these medications based off peak inspiratory flow rate, which has been studied before, is it working? Right? And again, only 20%. We have 10 people that had medication changes. But when we look at chi-squared, we did have significant results. I had significant results. However, chi-squared, it's usually with larger database, larger samples. So for validity, and because I didn't want to come out and say, oh, yeah, this is it right here, right? For validity's sake, as best as we can with the patients that I have and that type of thing, we ran a Fisher exact, and it was showing as not significant. But if we look at our P of less than 0.05, we're fairly, statistics are statistics, but I feel like maybe if we had a larger sample, we can hopefully, in my heart, I find it to be significant. These patients using their inhalers appropriately. So we'll call it not significant at this point based on our Fisher exact where we use for a smaller sample size. So I'll state these results are somewhat inconclusive at this point, but I still feel like they're pointing to a good direction. The resulting p-value, we talk about 0.07 with the conventional significance level set at 0.05. The observed association does not reach that statistical significance. However, it's worthy of noting that the p-value is marginally above the threshold-ish, suggesting hopefully a trend towards significance. And that's not to say that it's not significant. It's just saying based off what we have here, we can't really say 100%. Yep, PIFRs are the only way to go. And so we look at multiple variables by grade, and we look at our linear trends here, our R-squared and R's, our Pearsons and things. And if we look at age versus peak inspiratory flow rate, right, I can see it right there. Okay, the lower the age, generally the higher, and we found that. And these ones here on the bottom, we're looking at the male, female, and that would essentially just be kind of a trend line. Our length of stays, again, oddly enough, were lower for some of those more severe patients and somewhat higher for our grade 2s and 3s. In our social determinants of health, we can look at the numbers, but we see these bar graphs, right? Grade 0s, prisms, preserved ratio, impaired spirometry. These early COPD patients have much higher social determinants of health, and it could be, generality, could be that they are facing this lung disease. And as I said in previous lectures, nobody says I need to quit smoking. It's all I need to quit eating this. I need to work out more. So that's multiple variables by grade. And again, these are our total averages that I found using basic statistics. So it's a pandemic, right? COPD, and it doesn't seem to be gathering much attention, right, in relation to other diseases such as heart disease and cancer. And I believe this has come from a desensitization of people. And I've said this before. Aunt Fancy died of that COPD. Love her heart, okay? So with the advent of vaping, new designer drugs that are probably going into these vaping things, the ever-growing pollution that we continue to find ourselves in, pollen and that type of thing, this problem is sure to evolve, as we see with the growth of 200 million patients by 2050, I believe is what it was. This monumental economic impact of COPD is alarming beyond that of immediate intervention. I mean, it has to be long term here. Peak inspiratory flow rate, PIFR guided inhalation therapy, is individualized care. And as we move towards this value based versus volume based individualized care plan, the procedure is non invasive, it's super easy to perform, it's super fast, it's dual functioning in that it tells me what the patient can do and aids me in teaching them and how best to do it, especially as we see with PMDIs and that type of thing. However, peak inspiratory flow rates, as much of the inhaled medication realm is misunderstood or underutilized. And we got to say that DPIs are one size fit all, and neither is, I won't say standardized care, but we take standardized care and then we can tailor it to those patients. Peak inspiratory flow rate limitations seem to be most prevalent in individuals over 60 years old, females less than 65 inches tall, and those with grade 3 or grade 4 COPD. The limitations that are non-exhaustive in this research impact one of the direct causes of symptoms in COPD population, airway diameter. Okay, so this limitation, again, non-exhaustive. Proper and effective inhaler use is paramount. This research brings much discussion, and I've talked with tons of folks about the same kind of thing, right? As is some of the current research, PIFR-guided therapy, this pilot provides some inconclusive evidence concerning the potential benefits of PIFR-guided inhalation therapy in COPD management, and further research is needed. And there is research, as we talked about a little bit earlier, that points to PIFR-guided medication therapy with a readmission decrease of roughly 10%. Moving forward, future studies should aim to address these limitations that I have found and that I was unable to address, incorporating a larger sample size, multi-center collaboration, more correlative variables, and standardized protocols for peak inspiratory flow rate assessment and documentation. More so, longitudinal studies. I said this needs to be a long-term thing, folks. Longitudinal studies are warranted to evaluate the long-term impact of PIFR-guided inhalation therapy. And so, on clinical outcomes such as exacerbation rates, quality of life, and healthcare utilization, including readmissions. We should probably try to implement PIFR in recording inpatient and outpatient. Would be a great study that I'm not able to do. It's the idea for somebody out there. We want to develop a readmissions team. So, for instance, I meet monthly and quarterly with pulmonologists, some of the hospitalists, and we set standards as a team. Do we want to have it at 20% readmissions, so on, so on, so on. Right now, I'm sitting at about 15.6% average. And of course, sometimes these summer months can bring the patients in. We want to use proper verbiage and remove diagnosis where diagnoses are not available. That's a big one. Smart phases to address this. Could we just pop something into the chart and say, hey, this patient don't have COPD? We look at inhalation or inhaler financial assistance programs. Some of them for select few patients, sure, right, whatever. It's $35 for some of those that are $300, $400, $500, $600 for some of those. So I kind of ask, right, can we integrate it easily? If so, what are the costs and trainings? It can be integrated at the snap of a finger. I think you can buy those things for like $30 or $60. Don't quote me. And do we need to train anybody? So, if we're a respiratory therapist, probably not. Maybe, hey, this is how you do it. This is how you should coach them through it. Is there an agreed upon threshold for medication changes other than the listed in the study? We look at weak negative correlations for social determinants of health versus age grade, suggest further exploration into those subgroups. And of course, larger sample size to define the link. And I think could we do it? I think it would be easy. And can we just throw the PIFR into the order set, please? There's my references, folks. I hope you've learned something from it and that we can continue to build upon it. Available for questions. Keith, I'll hand it back to you and appreciate you all coming.